Hey class, it's Ashley Tharp, and I'm going to discuss a patient that I seen this past week in clinical. She was a 40-year-old Caucasian female who presented to our emergency room for chest pain, and it was later discovered that she was having a heart attack, so actually a non-STEMI, and this was her second heart attack in the last 3 years. We were consulted with Wellness Recovery, which is who I do the clinicals with this rotation, because of the complicated history of alcohol abuse. The patient reported that she had abused alcohol for greater than 10 years, that it actually started when she had a stillborn, and this was her way of coping with the pain and the grief. So the patient said that she had been drinking the last 9 years about 1 to 2 pints of liquor nightly. And over the course of this past year, she had self-weaned down to 2 to 3 drinks nightly. At the time that we evaluated her, she had no signs and symptoms of alcohol withdrawal, no DTs. So she had no nausea, vomiting, diarrhea. She had no restless legs, no diaphoresis, no runny nose, and no hallucinations, no delusions, and no seizure activity. She did have a past history of having withdrawal seizures, and her past mental health assessment included bipolar disorder and PTSD. So she was currently on Abilify and Zoloft, which we kept her on that. She was doing well with that, she said. Given her history of failed outpatient and inpatient rehabs and failed medication management from Antabuse and Vivitrol, we suggested Campril. And with the Campril, she seemed very receptive to this. So we started her on 666 milligrams 3 times a day and gave her the patient education that this medication will not lessen withdrawal symptoms, but it can help curb that intense craving for the alcohol. We also talked about the side effect profile, and you can read about that in the paper that I'm going to be attaching to this. In addition to the Campril, we also started her on thiamine and folic acid and a multivitamin. So with alcoholics, it's very important that you monitor their thiamine and folic acid levels, because especially with the thiamine, if they get deficient, they can end up with Wernicke's encephalopathy. So the other thing that we did for this patient is we set her up for outpatient treatment that was in her hometown that was specific to alcoholism. She felt very uplifted and hopeful with this treatment option, as she had declined the inpatient rehab. We gave her the diagnosis of alcohol use disorder severe with an ICD-10 code of F10.20 and cannabis use disorder mild, which is F12.10. She did have a positive urine toxicology on admission for cannabis. Safety, always a huge consideration, even though the patient at the time of the interview was not having any suicidal ideations, thoughts, plans, or intent. That is subject to change, especially as we start new medications like an SSRI or something along that lines that can alter their mental status and change their behaviors and characteristics. So we want to discuss suicidal prevention with this patient. We also talked to her about the dangers of medication noncompliance and the dangers of alcohol abuse. We offered the long-term rehab, and she declined. We also offered smoking cessation, and she declined. And she just said she wants to get better. She said, I need help, and I'm tired of living this way. Her MSE was pretty unremarkable, and you can read about that as well in the paper that I'm attaching. So thanks. Have a great day.